So, good evening, everybody, and welcome to this Ortho Excellence series. I'll hand it over to Dr. B. Shivshankar for further proceedings. Over to you, sir.
Thank you, Dr. Ashok. Friends, this is the 9th talk in the series of Ortho Excellence series for a young orthopedic surgeon under the age of 50 years who has done a great work in a specific field. Today, we have Dr. Tarun Suri, Associate Professor from Maulana Azad Medical College, New Delhi, as speaker. He will be sharing his experience as a spine surgeon, approach to thoracolumbar spinal injuries. I welcome all of you for today's meeting. We also have panelists in the form of Dr. Gurraj Sangondimat from New Delhi, Dr. Sanjeev Bhandari from Sholapur, Dr. Praveen Sarda, spinal surgeon from Solapur, and again, Dr. Priyank Patel, a specialist spine consultant from Mumbai, as our panelist today. I welcome all of you for today's meeting. To introduce our speaker, Dr. Tarun Suri, he is a consultant spine surgeon and associate professor at Maulana Azad Medical College in the Department of Orthopaedics. He has done his MBBS and MS from Maulana Azad Medical College. Then subsequently he has done DNB Orthopaedics and fellowship in spine surgery with Dr. Soumyajit Basu at Park Clinic in Calcutta. He has also worked as a spine fellow with Dr. Sandeep Chatterjee in Kolkata in the Department of Neurosurgery in the Park Clinic. He has been faculty for various national and international conferences, written many chapters related to spine pathologies, including the textbook Turex Orthopaedics and G.S. Kulkarni's textbook of Orthopaedics. He is on the member of Research Committee of Association of Spinal Surgeons of India. He is also member of AO Spine Cervical Classification Validation Group and is elected AO Spine India delegate. Welcome, Dr. Tarun Suri.
Thank you, sir.
We have Dr. Gurraj Sangondimat, consultant and unit head in the Department of Spine Surgery at Indian Spinal Injuries Center. He was the last speaker in the Ortho Excellence series. He has some difficulty in joining because he's out of Delhi today, but he might be trying to join, and if possible, he'll be joining. He has done his MBBS and MS from St. John's Medical College in Bangalore. Then he has done fellowship in spinal surgery, and he has done many fellowships in Munich, USA, Japan, Italy, etc. And he is also a member on the Community Development AO officer in the AO Spine for the Indian subcontinent region. He is a member of Education Committee of ASSI and former executive member of ASSI. We have a senior orthopedic surgeon, a trauma surgeon and a spine consultant at Sholapur, that is Dr. Bhandari. He has special interest in keyhole surgeries in the form of endoscopic discectomy and vertebroplasty. He is IOA Executive Committee member representing Maharashtra State in IOA. He is past president of Maharashtra Orthopedic Association. He is working as associate professor of orthopedics in Government Medical College, Sholapur. And he runs his own hospital, Bhandari Hospital, and is also attached to Ashwini Sarkari Rugnalaya in Solapur. Welcome, Dr. Bhandari.
Oh, thank you, Shiva. Thank you.
We have a consultant spine surgeon in the form of Priyank Patel, who works at Jupiter Hospital, Leelavati Hospital, Breach Candy Hospital in Mumbai. He has finished his MBBS from Mumbai, then MS from Nasik, and he has received the Spine Foundation Fellowship to do the fellowship in spine. He has worked at various centers across the globe in the invasive spine surgery from Chicago, USA, fellowship in spine oncology from Bologna, Italy. He is a part of several national and international organizations like ASSI, Bombay Orthopedic Society, AO Spine, North American Spine Society, etc. He has 11 years of experience in the field. He has also various national, international presentation and publication to his merit. He attends various conferences and workshops to keep himself updated as a delegate as well as a faculty. Minimally invasive spine surgery and spine tumor surgery are a special interest. He is also involved in various teaching and philanthropic activities of the Spine Foundation from Mumbai. Welcome, Dr.
Thank you, sir.
We have Dr. Praveen Sarada from Sholapur. He has done his MBBS from PDM Medical College, Amravati, then D-Ortho from Sancheti Institute of Orthopaedics and Rehabilitation, then DNB Ortho from Baptist Hospital in Bangalore. Then he has done spine surgery fellowships in Nagpur as well as Sean Clinic in Germany. Welcome, Dr. Praveen.
Thank you, sir.
Next week, not next week, day after tomorrow, on 15th Thursday, we have the do's and don'ts in hand surgeries by Dr. Hemant Patrankar, hand surgeon from Mumbai. I request all of you to join day after tomorrow at same time, that is 5 p.m. for his talk on do's and don'ts in hand surgery. Without much wasting of time, I now hand over the proceeding to Dr. Tarun Suri, the speaker for today on approach to thoracolumbar spinal injuries. Over to you, Tarun.
Thank you so much, Dr. Shivashankar, for this opportunity. So without wasting any time, I'll just start with my presentation. So I'll be speaking on approach to thoracolumbar spinal injuries today. Thoracolumbar
not shared it. Oh, you are not shared it.
Okay.
Yes.
Okay. The thoracolumbar region is one of the most common site of spinal fractures, with more than 60% fractures occurring in the spine at this region. The large majority is transition zone from T10 to L2. Now that is because the thoracolumbar region is a transition zone between a relatively stiff thoracic spine and a mobile lumbar spine. And anatomically, the orientation of facet joints changes from coronal orientation in the thoracic spine to saddle orientation in the lumbar spine. So that is also one of the reasons why it becomes very prone to instability. The outline of my talk would be in the following stepwise fashion. So starting with a brief touch on the clinical evaluation. Initial assessment of the patient with presenting to us in the emergency is very important in the form of adequate history, eliciting the mode of injury and examining the patient as per the ATLS protocol. Secondary survey should look for any occult spinal injuries. Examination of the extremities, pelvis, chest, abdomen is very important to look for any associated injuries which might have an result on the outcome of the patient. And a detailed neurological examination as recommended by American Spinal Injury Association is extremely important, in which you examine the motor power of the 5 key muscle groups in the lower limb in case of thoracolumbar trauma. You look for sensations in the various dermatomes and give a score which is called as ASIA score. We also classify the injury as per a grading system given by the ASIA. And apart from this, a very important part of the examination is the examination of the perianal region and the rectal reflexes. Most importantly, the reflex which is called as bulbocavernosus reflex should be examined and its status documented at the time and periodically, because it is the reflex which is the first reflex which to come after a state of spinal shock. So labeling that the bulbocavernosus reflex has come back means the spinal shock is over, and whatever neurology the patient is left at, probably that is going to be permanent. And it is very important to classify the injury as a complete spinal cord injury and versus an incomplete spinal cord injury. Moving to the radiological evaluation. The radiological evaluation is in the form of plain X-rays of the thoracolumbar spine, essentially the AP and the lateral views. Other X-rays to look for other injuries are important. We also get NCCT of the involved region in case we detect an injury, and an MRI of that region may be required, along with a possible screening of rest of the spine. So let's look at what all value do each of these add. Looking at the AP X-ray of the thoracolumbar spine, we have to look at, first of all, the alignment of the spine. All the spinous processes should be collinear, and if there is any drift in the spinous process of the proximal and the distal part, that might indicate a translational and an unstable injury. We should also look for a fracture of any transverse process, which although are minor fractures, but they should be documented. We should also look for any loss of vertebral body height as compared to the adjacent vertebral bodies. Other thing to note is the distance between the two pedicles. Widening of the interpedicular distance might be an indication of a burst fracture. So it is very important to look for a widening of the interpedicular distance on an AP X-ray. Sometimes there is a increase in the interspinous distance which is appreciable on the AP view, and if it is so, that might indicate a flexion distraction injury or an injury to the posterior ligamentous complex, which is very unstable. So if visible, these kind of injuries signs should be documented on the AP view. Coming to the lateral view gives us more information in the form of loss of the vertebral body height, which can be compared to the upper and the lower adjacent vertebrae. We have to look at the amount of kyphosis, because the thoracolumbar junction's sagittal alignment is essentially straight. The kyphotic angle or the Cobb's angle at the thoracolumbar junction is 0 degrees. So any amount of kyphosis is an indication of an injury, and a kyphosis more than 30 degrees might indicate an injury to the posterior ligamentous complex and an unstable injury. We should look at a loss of posterior vertebral height as well, which might indicate the involvement of the middle column and might add to instability. Any posterior cortical bulge might be a marker of a retropulse fragment. We should also look at the loss of the spinal alignment. For example, in the middle X-ray below, we can see that the posterior vertebral line of the proximal and the distal part of the spine are not in same line. So this kind of loss of spinal alignment might be an indication of a fracture dislocation. Now, coming to the role of CT scan, an NCCT is required for classification and studying the fracture morphology, and it is a very important tool for the surgeon for surgical planning. Important things to evaluate in a CT are posterior vertebral wall, to see if the fracture is a burst fracture or a compression fracture, to look for the posterior elements, because an injury to posterior elements might signify an injury to PLC, and posterior elements are the first structures that you will, as a surgeon, encounter when you're exposing the spine. So you should know when exposing the spine whether lamina is fractured or not, so that you might not injure the neural contents inadvertently. We have to look at the amount of canal compromise on axial view, and we also have to look at the status of the pedicles at the fractured vertebra and at the adjacent vertebra. That is because we are essentially going to fix the spine with the help of pedicle screws. So it is very important to document the integrity of pedicles before you start putting in screws. So this is just a small video of how the CT scan needs to be evaluated. These are the coronal CT images, and we're moving from back to front. So as we move slowly, we can appreciate that pedicles at these two levels on both sides are fractured. So these fracture lines are appreciable. It is very important for an operating surgeon to study the CT scan in detail, either by sitting himself at the console or looking at the films very clearly to look at these small points which can help you in during the surgery. So as we move from front back to front, we can appreciate that there is a fracture, horizontal fracture in the vertebral body as well. Now, I would like to highlight at this point of time that apart from the spine, we should take this opportunity to look at the abdomen and the chest also, because sometimes injuries which are not visible on the X-ray or are not clinically apparent, such as a small hemothorax or a hemoperitoneum, might be visible on a CT scan, which can change your treatment strategy. Coming to the sagittal view again shows the decrease in the height. It clearly shows which part of the vertebral body, anterior, middle, posterior, are involved. So you can see that there's a fracture line running from front to back. There is also a kyphosis, and the fracture line seems to going into the posterior elements, as you can see in this cut. I would also like to point out this cut specifically, which should be very carefully examined, because this cut shows the facet joints. Now, these joints should be very carefully evaluated in any thoracolumbar injury, because any form of minor subluxation can be missed on the X-ray, but any kind of facetal fracture or a subluxation of one of the facet joints can add to the instability component of the injury, and you might need to approach the injury in a different way. So facet joints should be evaluated very carefully. Coming to the utility of MRI. MRI is required whenever there is a neurological deficit, whenever there is a mismatch at the fracture level and the neurological injury, for the assessment of posterior ligamentous complex, for the assessment of the disc, and in any case where the patient is unconscious, a neurological examination cannot be done. Ganga Hospital has done a study of around 484 MRIs with thoracolumbar trauma patients, in which they have shown that a whole spine screening MRI definitely adds to the value by picking up non-contiguous injuries which would otherwise have been missed. Now, they detected in the study that they could pick up around 19% of patients had multi-level injuries which were not visible, apparent on the local X-ray. And out of those 24 missed injuries, 5 were unstable, which required surgery also. So this is probably a new pattern changing study which has come up, which might help us in uh, picking up any missed injuries. The problem here is definitely going to be availability of MRI uh, uh, for getting a whole spine screening done. Now, what is the importance of posterior ligamentous complex? Posterior ligamentous complex definitely has a bearing on treatment strategies and functional outcomes of the patient. It acts as a posterior tension band, maintaining the alignment of the spine, and any injury to it can lead to a progressive deformity and pain. Important thing is that superior PLC is essentially ligamentous, and it is a relatively avascular structure with poor healing potential. And therefore, PLC injury should be carefully evaluated to guide us in our treatment algorithms. In the MRI, one of the most important sequences which need to be carefully studied are the stir images. Now, stir images are a long TR kind of variant of T2 fat suppressed images, in which all the fat is suppressed, and in the stir sagittal images, all the fat which is present in the subcutaneous region or interspinous region is completely grayed out. So anything hyper intense that you see on the stir image is possibly because of edema. So you have to look at very carefully along the posterior ligaments whether there is edema or discontinuity present in the posterior ligaments, because presence of any PLC means that the injury might be unstable and you might need to approach it differently. So coming to the next part of the talk, the various classification systems for thoracolumbar trauma. Now, there are numerous classification systems for thoracolumbar trauma. One of the earliest classification systems began in 1930, and the timeline dropped out a classification system almost every 5 years, to the point where we have come to latest classification, which was given by AO Spine in about 2014 or 15. So we will just touch the important classifications and their important highlights only. The earliest classification for thoracolumbar injuries was given by Bohler, and he classified them into 5 categories, but there was no attempt to define spinal stability, and therefore this classification did not become very popular. The next important classification was given by Watson-Jones. Now, Watson-Jones, for the first time, recognized the concept of instability in spinal injury. He emphasized that the integrity of posterior ligamentous complex is essential for stability. Following this, we had Nicol classification, which was the first anatomical classification where he divided the spine into 4 anatomical structures, and depending upon which structures were important, he classified the various fracture patterns. And then came the column concept for the first time, which was given by Holdsworth. Holdsworth introduced 2 columns in the spine, anterior column and posterior columns, and based on injury to them, he gave 6 types of spinal injuries. The problem with the Holdsworth system was that he made it very simple biomechanically. For example, according to him, all burst fracture, whether it was in the anterior part or the middle part or whatever the kyphosis was, were labeled stable by him. And therefore, people recognize that this classification essentially had many problems. And therefore, in 1983, one of the most popular classification systems came, which was the Dennis classification. Dennis, for the first time, introduced the concept of middle column and gave a 3-column theory. So these are the 3 columns which were given by Dennis. The 3 columns are: anterior column consists of the anterior longitudinal ligament, anterior half of the vertebral body, and anterior half of the vertebral disc. Middle column is posterior half of the middle of the vertebral body, posterior half of the disc, and the posterior longitudinal ligament. And all the remaining structures, the neural arches, pedicle, lamina, facets, spinous process, and the ligaments, namely the supraspinous ligament, the interspinous ligament, the facet capsules, the ligamentum flavum, they all constitute the posterior column. Now, the Dennis classification was more of a mechanistic classification, and although it came out in 1983, but it remains indispensable even today. We still use it as orthopedic and spine surgeons. Dennis insisted that fractures with middle column injury are unstable, and he essentially described 4 patterns. Now, what are they? The first one was compression fractures. Compression fractures are fractures with injury to the anterior column only, where the anterior column fails under compression. The second category was burst fractures. In the burst fracture, there is an involvement of both the anterior and the middle column. There might be or might not be involvement of the posterior column, but essentially both the anterior and the middle columns are involved in burst fractures, which are caused by axial loading. The third category was seat belt fractures or chance fractures or flexion distraction injuries. They are called as chance fractures because they were first described by a person called as Chance, and they are as a result of a flexion distraction vector acting anterior to the spine, where the anterior part of the body fails under compression, while the posterior and the middle column, they fail under distraction. So there is opening of the spine from in the middle and the posterior columns. And the last category, which was the most unstable, were fracture dislocations, where there was a failure of all 3 columns with dislocation of the facet joints. So these are the 4 patterns which were described by Dennis: compression fractures, burst fractures, seat belt injuries, and fracture dislocations. Now, column concept, 4 important injury mechanisms and configurations given, but still Dennis classification had some demerits. The demerits were that it did not guide us for treatment protocols. There were no guidelines as to how to approach each fracture in a different way. He labeled any in 2 column injuries as unstable. But now we know that we have a category called as stable burst fractures, in which there is involvement of both the anterior and middle column, but the fracture might be stable and might not require surgery. He did not address the ligamentous injuries, which we now know that injury to PLC is so important because it leads to progressive deformity and kyphosis, which was not addressed in Dennis classification. And in Dennis classification, he did not make any any difference between stable and unstable burst fractures. According to Dennis, all burst fractures, because they involved 2 columns, were unstable. So this was these were few lacunae of the Dennis classification. So to correct these, the next classification system came, which was given by McAfee, for the first time based on the study of 100 CT scans. He described 6 groups, but the most important thing to remember about McAfee classification is that he distinguished burst fracture into stable and unstable for the first time. So for the first time, he gave the concept that there is a stable burst fracture and there is an unstable burst fracture. Now, what were the instability criteria? The instability criteria probably are used now also for labeling a fracture, burst fractures unstable. The presence of any neurological deficit automatically makes injury as unstable. A kyphosis at thoracolumbar region of more than equal to 20 degrees, a height loss of more than 50%, facet joint subluxation, and retropulsion of the fragments in the canal with CT were all described as signs of instability by McAfee. So after this came another classification, which was McCormack load shedding classification. Now, why did this come up? In late 1980s, the concept of short segment fixation with VSP. VSP were vertebral stabilization plates or Steffi plates, which were used in the 80s and the 90s. That started coming up. The studies started coming up that you were able to manage these fractures with short segment fixation also, and long segment was not required. But on follow-up of these patients, some had implant failures. So McAfee did a CT scan based study of 28 patients. Noteworthy is that this classification was given based on study of only 28 patients of these fractures and evaluated 3 parameters, namely the amount of comminution, the amount of apposition of fragments, and how much was the deformity corrected between the pre-op and the post-op X-rays. And after the posterior surgery being done, these parameters were evaluated and the score was calculated. If the score was more than 7, McCormack said that there is a high chance that the short segment construct will fail and you probably need to do a second surgery where you need to reconstruct the anterior column. So this was supposed to be a path-breaking classification which was given by McCormack, but several review articles, several studies were done using the McCormack classification, and one of the review article which was published recently showed that although it was developed to predict the need for anterior stabilization, many studies have shown that we are not now able to manage short segment pedicles to construct which may be sufficient without any need for an anterior reconstruction. So although this classification became popular for some time, and many people still use it in the guidelines, but most of the literature says that McCormick classification has not added significant value in predicting the failure of the anterior column. The next classification given by the AO group, which became very active in the 1990s, was the AO classification popularized by McGill. Now, AO classification is based on AO classification is just like classification for any other long bone in the body, where we have a 3 by 3 by 3 grid, progressive alphanumeric scale, which as we go higher, the severity of injury, the amount of instability, it increases. It's a more comprehensive classifications where they have described many number of morphological types of fractures. So we will just briefly discuss what are the different types of injuries on AO classification. Type A, Type B, Type C are three broad groups, where Type A are compression injuries, Type B are distraction injuries, and Type C are translation injuries. In Type A, you have A0 to A4, where A0 are minor non-structural fractures such as those of spinous process, transverse process, which are only minor fractures. Type A1 is a wedge compression fracture. Type 2 is a split fracture of the vertebral body. And types A3 and A4 are burst fractures. A3 is an incomplete burst where there is involvement of only one end plate. A4 is a complete burst where there is involvement superior and inferior end plate both. Type B are flexion distraction injuries. There is B1, B2, B3. Both B1 and B2 are flexion distraction. The difference is in B1, the fracture lines goes posteriorly through the bony element. So it's a bony disruption. In type B2, the injury line goes posteriorly through the ligaments. So it's a ligamentous disruption. And type B3 are extension distraction injuries, which typically and classically occur in patients with ankylosing spondylitis. And type C are translation injuries, which might include rotational injuries and fracture dislocations also. So as we can understand, as we move from A to C, and within each category, as we move ahead, the instability and the severity of the injury increases. So what were the ups and downs of the AO spine classification? Now, AO spine was given by an AO spine study group, so it was a collaborative classification with inputs of many surgeons across the world. It defined clearly recognizable primary groups, and with increasing severity, there is a increased chance of neurological deficit could be predicted by moving down the grid. The disadvantage were that there were more than 50 subtypes were described with subdivisions. So the reliability and remembering it for the surgeons is also very difficult. There was no clear demarcation of stable versus unstable. There was no clear line drawn where the stable injuries stop and the unstable injury starts. And no clear-cut surgical guidelines were given at the time the classification came out. So the next classification system came up, which was given by the Spine Trauma Study Group by Vaccaro et al. In 2005, which is called as TLIX. TLIX stands for Thoracolumbar Injury Classification System. Now, this is one of the most important classifications which is used nowadays, and this is one classification which we frequently use in our decision making. Three variables are evaluated: the mechanism of injury, what is the integrity of posterior ligamentous complex on the MRI, and what is the neurological status. So depending upon what the fracture mechanism is, you allocate points: 1 point for compression, 2 for burst, 3 for a rotational injury, and 4 for distraction. You allocate points for the neurological status of the patient. So you start from 0, which is for intact patient. For any nerve root injury, you give 2. For any complete cord injury, you give 2. And for incomplete injury, you give 3. What is important to notice that higher points are given for incomplete cord injury. That is because the prognosis is better for an incomplete injury, and we need to be more aggressive for a patient who has incomplete spinal cord injury. Again, posterior ligamentous complex is given points: 0 for intact ligament, 2 for indeterminate injury, and 3 for a definite injury. Important to notice that there is no 1 here. We straight away move from 0 to 2. So we make a sum of all these 3 parameters for the injury, and the total sum is used to guide us whether to manage the patient conservatively or surgically. The cutoff which was decided was 4. So any score less than 4 essentially meant the patient could be managed conservatively, and any point more than 4 means surgical intervention would give a better outcome. The score 4 per se was a gray area, and it was left for the surgeon to decide, depending upon discussion with the patient, what are the expected outcomes and various other factors, whether a surgery might be needed or not. So this classification made it very easy for us to decide whether the surgery is required or not. It looked that it could be done by anybody, and he could decide that if a patient required surgery or not. So it was very easy to use and apply, and probably the most important point about this classification is that after so many years, this was one of the first classifications.
Gururaj, please mute yourself.
The disadvantages were that it was not able to convey the fracture personality. We saw in AO classification how we could just tell the number and would imagine what type of fracture it would be, but here it was not that comprehensive. The natural history of occult PLC injuries is unknown. Now, although we have given so many importance to PLC in this classification, several studies later on showed that a posterior ligamentous injury, especially if it is occult, we might know how it would affect the fracture. So the natural history was not known. And several studies were done after this, in which people compared the MRI findings of PLC with the operative findings, and they concluded that the MRI overestimates the amount of PLC injury. So probably this classification had an inbuilt error, that it was more skewed or balanced toward the surgical side. And also for this classification, availability of MRI was essential. So this classification also had several drawbacks. And the last classification, which came out in 2013 and 14, AO group and TLIX, the last two classifications, they combined together to come out with the thoracolumbar AO spine injury score, or the combined classification. It's a very comprehensive classification where they again allocate points to each morphologic group, each neurologic group, and they sum up all the points, and they come out with what is called as AO spine injury score. Now, this came out in 2014, but validated studies are still awaited as to what is the surgical threshold score, how much score should be required for this classification to label whether a surgery is required or not. So we have so many choices. There's a problem of too many in the classifications. So what are the most important ones to remember and use? So the most important ones that we use in our practice are Dennis classification for injury description, AO classification for injury description or for communication amongst each other, and TLIX score for decision making. So I would say that after all these slides, this is the most important one, where we decide that these are the three classifications that we are most commonly using in our day-to-day practice. So after this, we come to the next part of the talk, which is approach to specific injuries. Now, broadly speaking, we can decide the approach depending upon what is the kind of injury on AO spine classification. So if you have an A0, means a minor fracture of transverse process, spinous process. If you have an A1 injury, which means simple compression fracture, or you have an A2 fracture. A2 means a split fracture of the vertebral body, where there is no injury to the medial column or the posterior column. Generally, no surgery is required. For A3 and A4, we need to individualize, and we need to discuss in detail what kind of surgery may be required for different settings. For type B injury, which are distraction injuries, surgery gives a better outcome because these are highly unstable injuries, 3-column injuries, and therefore surgical option is always preferred. And type C is translational injuries, for example, fracture dislocations, which are inherently unstable, and surgery is the treatment of choice for them. So let's move ahead and discuss the most controversial area, which is the A3 and the A4. So just to give some examples, the A0 is the spinous process or transverse process fracture, which are, as I told you, managed conservatively. A1 are the fracture of the anterior column, which are the wedge and the compression fractures. So as you can see in the CT scan, there is only fracture of the anterior column, and this can be managed conservatively. A2 is a split or a pincer fracture. Again, the posterior columns are intact, the middle column is intact. So this is also managed conservatively. Then we come to the A3 fracture, which is incomplete burst fracture, means involvement of only one end plate, and A4 fracture, where there is involvement of both end plates and retropulsion of fragments into the canal, which is a complete burst fracture. Okay. Now, the first scenario is A3, A4 means a burst fracture with an intact neurology, and a stable burst fracture. So we have a stable burst fracture with intact neurology. Now, what is the evidence in the literature for it? So a randomized prospective study was published in JBJS comparing the operative with non-operative treatment for these kind of fractures, and it was seen that at long-term follow-up, those with a stable burst fracture who were treated non-operatively, they had better clinical outcomes in the terms of pain and function as compared to those who have been operated upon. However, some other studies have shown that the operative group had better correction of the kyphosis, they have better pain scores, they have better back to occupation rates as compared to the operative group. So the literature is divided, but most of the literature, most of the studies, including a Cochrane review of all the available studies, have shown that there is no statistical difference in functional outcome 2 years or more after between the operative and the non-operative groups. So most of the studies is in the favor that similar outcomes are present with surgery and conservative, but the complications which you might get with surgical group, they outweigh the benefit over the conservative group. Also, if you apply TLIC score to this group, A3, A4 with intact neurology and stable burst morphology gives a TLIC score of less than 4. So conservative is essentially the mainstay of treatment for any stable burst fracture with intact neurology. Coming to the next group, we have unstable burst fracture with intact neurology. So first we discuss a stable burst with intact neurology, which was managed conservatively. Now we come to unstable burst with intact neurology. Again, the literature is divided on benefits versus no benefits, and the advantages of surgery versus the complication risks should be discussed individually with the patient. Early mobilization, prevention of late kyphosis may favor surgical options, and the balance is little bit in favor of surgery as compared to conservative for these kind of fractures. So unstable burst fractures mean with intact neurology mean those burst fractures who have a kyphosis more than 20 degrees, more than 50% height loss, canal compromise, they should be managed conservatively after discussion with the patient. Coming to the third category, A3, A4 fractures with neurological deficit. Now, by definition, any kind of neurological deficit makes the injury unstable. Now, there is a case for surgical intervention here. TLIC score also, if you calculate, will come out to be more than 4. So surgery is done for most of these cases here. Incomplete injuries are managed more aggressively versus the complete injuries because there is a chance of better prognosis with these patients. So early surgery is recommended for incomplete injury patterns. But the catch is that neurological recovery, even after so many literature being published, is still unpredictable. The primary aim of surgery, even for these cases, remains surgical stabilization. This was a landmark paper in Clerk, published in 1998, where he did CT scans of patients managed conservatively 1 year after the trauma. And he proved that there is spontaneous remodeling of the spinal canal even after you manage these cases conservatively. So canal clearance by surgery does not give any added benefit because the same happens by the natural history also. Another review article, which was to look at the point whether canal clearance affects certain neurological outcome after thoracolumbar burst fractures, also summarize that surgical treatment is not necessary for neurological reasons. Patients should be adequately counseled that it is primarily because of for surgical stabilization that you are being operated. Neurological recovery for burst fractures is no better after surgery than after non-surgical treatment. Another study which studied that whether surgical intervention or timing of surgery has an effect on neurological recovery also had a similar outcome. So to look at this diagram again, where we were going to individualize the A3 and A4, they can be individualized like this. If a patient has a stable burst fracture with an intact neurology, he is to be conserved. If a patient has an unstable burst fracture with intact neurology, surgical option should be given to the patient. If a patient has an unstable burst and if there is a neurological deficit, a surgery definitely should be done. But the evidence for benefits of surgery are poor. What are the aims of surgery? The number one aim of surgery that should be explained to the patient and even documented, that the aim is surgical stabilization for early mobilization and rehabilitation of the patient. The second aim is to correct the deformity to prevent late and progressive kyphosis. And neurological recovery is unpredictable, as I showed you in the previous slides, as the literature definitely shows that neurological recovery after surgery and no surgery might be on the similar grounds. So these were the various patterns of type A in the AO classification, how they should be managed. Coming to the various surgical considerations. What are the various surgical considerations which have to be kept in mind? So the first consideration is timing of surgery. When should surgery after thoracolumbar spinal trauma should be done? So surgery should not definitely be done in the middle of night. No spine surgery outcome has been shown that it is better if you operate as soon as the patient comes to you. So timing of surgery in thoracolumbar spine, several studies, including the latest one published in 2019, has shown that 72-hour cutoff should be respected. A 72-hour cutoff respects the most promising time window during which surgical decompression has the potential to offer a neuroprotective effect in the setting of an incomplete spinal cord injury. So if you get a patient who has an incomplete deficit, we should try and operate him within the 72-hour window, which has shown to have better neurological outcome as compared to a late surgery. Apart from that, the timing of surgery might also affect the approach that we are going to use. One of the most common surgical principles that we use for reducing thoracolumbar fractures are pedicle screw based ligamentotaxis. We put in pedicle screws and we distract between the pedicle screws to gain the advantage of an intact posterior longitudinal ligament and do an indirect decompression of the canal. So this study which was published shows that posterior surgery works well with low risk of implant failure if done within 2 weeks. But if you are delaying the surgery for more than 2 weeks, then the surgery, the canal clearance, indirect canal clearance would become more difficult, and it probably would require an additional anterior support procedure to prevent further loss in kyphosis and implant failure. So after timing of surgery, the next surgical consideration is which approach would you like to use? Anterior approach, posterior approach, maybe a both. So anterior approach serves all the aims of stabilization which are required. It can achieve a direct and complete canal clearance. It can achieve same kyphosis correction as posterior, and it can reconstruct the anterior column to prevent late kyphosis. But the drawbacks are it is technically demanding with high morbidity. It has to be delayed until the patient is stable and is usually reserved for lumbar spine or severe comminution of the body. So these are the disadvantages of anterior approach. Posterior approach also serves the same aims, but the canal clearance is usually indirect and incomplete. Kyphosis correction is same as that of anterior approach, and reconstruction is a little unsatisfactory as compared to anterior approach, but it is technically easier with low morbidity. Canal clearance, neurological recovery, as I discussed in the previous slides, the value and the predictability is not scientifically established. There is indirect correction of kyphosis and canal engorgement, and therefore it is suitable for fresh fractures ideally. So after the approach, we come to the next surgical consideration, whether we should, how many pedicle screws should we put, whether you should do a short segment fixation or a long segment fixation. So the conventional short segment fixation was just skipping the fracture, putting one screw above, one screw below. Initially, it was done by other stabilization systems such as the Steffi plate, but now pedicle screws and screw rod constructs have come up. So that was the conventional short segment fixation. But now a short segment fixation is being done with what is called as index screw. If you look at the lower panel of the X-rays and the images, you will see that one screw has been put into the fracture vertebra. This is called as an index screw. So this also qualifies as a short segment fixation. So this study was published in 2007 for the first time, where an intermediate screws were put in vitro in the recreated thoracolumbar fractures, and a biomechanical study was shown. And it was shown that addition of intermediate screws at the level of a burst fracture significantly increased the stability of the construct. And thereafter, the number of studies using this technique, they increased tremendously. So many studies came up which showed that this technique definitely adds to the construct of the stability of the construct. So how it is done is we put pedicle screws one level above and one level below the fracture vertebra. And after carefully studying the CT scans and if the pedicles of the fracture vertebra are intact, we've tried to put at least one and preferably both side screws into the fractured vertebra. Usually a short screw goes in a oblique trajectory, and after putting in that screw, a straight rod or a contour rod is put, which helps reduce the kyphosis and restore the vertebral body height. So using this technique, what are the various strategies that can be used during the surgery for reduction? The first is postural reduction. If you are operating the patient within a reasonable early time frame, as soon as you position the patient, because of the positioning on the bolsters and induced lordosis, the kyphosis many times reduces itself. So that is one advantage that you get by doing an early surgery. The second strategy that can use is you can pre-contour the rod. We can use a straight rod because the thoracolumbar junction is essentially straight, or give a very gentle S to the patient, and by pre-contouring, the kyphosis can get reduced. The third technique is cantilever reduction, which most of the spine surgeons are aware of. So you put in the pedicle screws and you apply the rod and tighten the rod to the proximal screws and slowly push the rod and capture the rod in the inferior screws so that the kyphosis gets reduced. And finally, we can use an indirect reduction technique where you can distract between the pedicle screws and you can tension the PLL, which is a posterior longitudinal ligament, and it indirectly reduces the retropulse fragments, thus helping to achieve the canal clearance. Okay, so short segment fixation has definitely in many screws studies shown advantages and similar outcomes as compared to long segment fixation. The advantages of this screw, which is called as index screw, are that it saves motion segments, especially in the lumbar spine. The lesser screws you put in the lumbar spine, more motion segments are available for movement. So it saves motion segments, which is a real concern in the lumbar spine. Putting a screw into the fracture vertebra is shown to have better control over the kyphosis, and it is also part of the lordosing screw. Some studies have shown comparable or even better clinical outcomes with index screw, including the fact that patients who have index screw surgery, they are able to tolerate mobilization earlier and better as compared to those who have not have screws into the fracture vertebra. The index screw restores the height of the vertebra, fracture vertebra better, which translates into lesser chances of adjacent level degeneration. And it has been shown that adding bilateral screws increase the stability of the construct by 25%. So these are several studies comparing the short segment versus long segment for thoracolumbar fractures, and all of them have showed that the short segment construct offers good correction of the kyphosis, the vertebral body height, and clinical outcomes. So this is just a case example of an 18-year-old boy who came to us with a fall from height, and there was a fracture of the, as you can see that there is a fracture of the L1 vertebra. There is a decrease in the height and there is local kyphosis. There was no neurological deficit. The MRI showed that there is no significant posterior ligamentous complex injury. And this patient was operated by, after discussing with the patient regarding the potential benefits of the early surgery, this patient was operated during the short segment technique, where you can see that screws have been put into, short screws and oblique screws have been put into the fractured vertebra. And we can compare from the first X-ray and the third X-ray that the height has been restored. The local kyphosis has almost become anatomical for a thoracolumbar junction. Okay, so after this, we come to the role of short segment versus long segment in type B injuries, which are flexion distraction injuries. Now, several studies have shown that short segment fixation can also be reliably used for flexion distraction injuries, especially type B1, which are the bony flexion distraction injuries. Adding fusion and doing a long segment can be considered if there is an extensive ligamentous injury, as you might get with the type B2 kind of injury. So I'll just show you with the help of a case. This is a patient with a with a 1 week old injury, young patient with a severe kyphosis because of the injury. You can see that there is around 40 to 50-degree kyphosis, and you can appreciate that there is opening of the posterior elements. So this is a flexion distraction kind of injury. So this is a CT which showed the fracture line going from anterior column to the posterior column. The MRI which showed a significant injury to posterior ligamentous complex. So in this case, there was a significant kyphosis. There was a lot of ligamentous injury to the posterior ligaments. So this classified as a type B injury with a type B2 variant, which was a ligamentous flexion distraction injury. And therefore, we did not take any chance by doing a short segment fixation, and we offered a long segment construct to the patient, and we could achieve a good correction of the kyphosis and restoration of the anterior column height. Next, we come to the B3 category, which is the hyperextension type of injury. The B3 injuries are typically seen in a patient with ankylosing spondylitis, where all the columns are completely ossified and AL gets ruptured because of the hyperextension torque. And generally, these are 3-column injuries, and because of the nature of injury, because of the biomechanical forces acting on the ankylosing spine, they usually require long segment fusion. And lastly, in type C injuries, usually there is no question of short segment constructs. These are fracture dislocations or translation injuries, which are considered to be highly stable. There is injury to facet joints, disc, and posterior ligaments, and therefore long constructs, usually 2 up, 2 down, are the preferred fixation technique, along with adding fusion, so that ligament injuries do not generally do not heal. So the fusion helps us to in the long term maintenance of stability and the deformity correction. So this is another case where we can see that there is a fracture dislocation. The first X-ray shows that there is a translation injury. If you draw the spinous process line, they are not collinear. You can see that the facet joints here are subluxed. The posterior vertebral body lines, they are not in the same line. The MRI confirms that there is an extensive cord injury, and we have operated by a formal 2 up, 2 down fixation, a long segment construct. Moving ahead, so the next surgical consideration that comes to our mind is whether to add fusion or not add fusion. We have done the surgery, but put in pedicle screws. Now the next step is to decide whether you want to add some bone graft there or you want to leave it as such. Now, there are several studies which have been done to look for the role of fusion, and most of them suggest that adjunctive fusion is not necessary when managing patients with a burst fracture of the thoracolumbar spine. Even when you're doing short segment fixation, it's a burst fracture. Addition of fusion does not give you any additional benefit. So results of short segment fusion fixation, without fusion are considered to be very satisfactory, but fusion should definitely be considered for type B2 injuries, just like the case we had discussed just now. So extensive ligamentous flexion distraction injuries and fracture dislocations, fusion should definitely be on your treatment protocol and during your surgical consideration. The next surgical consideration is how do you want to decompress? Whether you want to decompress, if you want to decompress, what should be the modality, technique, whether you want to do indirect decompression, you want to do direct decompression. So what is indirect decompression? Indirect decompression is that you do not open the canal, and you, by several other mechanisms, you try to push the retropulse fragments back to their place outside the canal. So the most common technique used is ligamentotaxis. We put in pedicle screws to posterior approach, and we distract between the pedicle screws. And this principle completely relies on intact posterior longitudinal ligament. The intact PLL, when distracted because of the ligamentotaxis, is thought to push the retropulse fragments back into the vertebral body. So we can see that the fragments are retropulsed here, and when a distraction is done, the intact PLL pushes them back. So it becomes very important to look for the integrity of PLL if possible in the sagittal MRI images. So in the first 2 MRI images, we can see that in the first image, the PLL runs across the posterior border of the vertebral bodies. And we can clearly see this black line that PLL is completely torn here. So in this case, the ligamento-taxis is not going to work. While in the second MRI, you can see that the black line continuity is maintained. So in this kind of injury, you can expect the ligamento-taxis to work for you. So what are the limitations of indirect decompression? The first limitation is that you have to do it early. Once the fracture fragments they start healing, the intact PLL will not be able to push them back. So it cannot be performed after 10 to 14 days of the trauma. The second limitation is that if there is severe comminution and there is a significant canal compromise, usually more than 60 to 70%, then this technique may not be able to completely reduce myodistraction. And it is also considered that with so much canal compromise, the integrity of PLL is doubtful. And the third is that if you see a reverse cortical sign, the posterior longitudinal ligament is likely not intact and ligamento-taxis will not work. Now, what is the reverse cortical sign? Reverse cortical sign is that the retropulsar fragments, they come into the canal and they rotate 180 degrees so that the cortical surface starts facing the cancellous part. If you look at this axial CT, we can see that this cortical bone is facing the cancellous part. So this is not going to unite with the cancellous bone. This indicates generally that there is severe disruption of the posterior longitudinal ligament and is one of the contraindication for ligamento-taxis. So that's why it becomes very important to study your CT scans very carefully to decide what and how you're going to approach the fracture. So after indirect decompression, we come to direct decompression techniques. Direct decompression can be done by anterior approaches, or more commonly, most of us now use the posterior approaches. Posterior approaches can be posterolateral or transpedicular approaches, where you do a hemilaminectomy and remove the pedicles. You go around the cord to the posterior vertebral body and you put a tamp, bony tamp there and push the fragments back into their space away from the dura. So direct decompression is usually done by the posterolateral techniques nowadays. Now, the type of whether to do decompression or not in type C injuries is very debatable. It is said the main cause of neurological deficit is the initial impact at the time of trauma. Also, the kind of neurological injury or the spinal cord neural injury in these kind of injuries is extremely high. The prognosis of recovery is thought to be extremely poor in these kind of injuries, and therefore the role of decompression is doubtful. And most of the surgeons, they generally do not add decompression while operating these injuries. They only do a surgical stabilization. So we come to the last aspect of the talk in the surgical considerations, the role of the minimally invasive surgery. Now, minimally invasive surgery has techniques have been developed for spinal trauma as well. We can put percutaneous pedicle screws. We can do minimally invasive lateral approaches for doing a corpectomy. You can use minimally invasive extrapleural anterolateral approaches for decompressions. And there is also a scope of doing video-assisted thoracoscopic surgery for doing anterior decompression. But the most common one, which is in our armamentarium, are the percutaneous pedicle screws. Now, a recent study was done showing the comparing the percutaneous versus open pedicle screws, and it was a systemic review and meta-analysis of various comparative studies, and it gave us a message that percutaneous approach was associated with a shorter operative duration and hospital stay, reduced blood loss, and reduced infection rates. The lack of good quality and randomized trials, however, was a problem in the meta-analysis, but the general consensus is that given with proper indication, percutaneous screws give us a favorable outcome and lesser complications, lesser problems as compared to open surgery. So what are the indications in which you can do a percutaneous pedicle screw fixation? The indications are type A3, A4 burst fractures without extensive ligamentous injuries and those who are neurologically intact. Any patient who has a deficit, you might not want to do a percutaneous pedicle screw fixation because a decompression would be required for whatever reasons it is worth. But an ideal indication would be an A3, A4 burst fracture, a patient who is neurologically intact and who does not have any extensive ligamentous injury. The second category can be a bony chance fracture without any deficit. It is definitely not for type C injuries. and it is not for patients who require surgical decompression. So, I discussed in the previous slides, percutaneous pedicle screw fixation has very well shown to be beneficial for bony chance fractures also, which was, as it was shown in this study, that the percutaneous uh, this technique was having the benefit of reduced operative time, reduced blood loss, and reduced tissue damage and early mobilization. There was no significant difference, however, in the correction of the kyphosis between the MIS and the open surgery groups. So this is another representative case which I just want to show. This is a case of a 25-year-old boy with a burst fracture, with an unstable burst fracture, significant kyphosis. He did not have a neurological deficit. So the CT scan did not show an extensive ligamentous injury. So the benefits of surgery were discussed with him, and he was given an option. And after thorough discussion, a decision for percutaneous pedicle screw fixation was done. And in this, apart from pedicle screw fixation, we also use the technique of index screw, where screws were put from both sides into the fractured vertebra. So for the short segment construct, the benefit is that you can mobilize the patient early. It has the blood loss is less, the pain, postoperative pain definitely is less with these kind of procedures. Percutaneous fixation also has some disadvantages. The first disadvantage is that you cannot add fusion. So if you cannot add fusion, there is always the question that whether would you like to remove the implant at some stage later on, because if you do not add fusion, the loads are transmitted through the implants. It may be a load bearing implant. So would you like to remove the implant so that the chances of implant failure are not there? So that becomes a question. The second is that you cannot add any anterior reconstruction through this technique. So there is a chance of implant failure, especially if you are doing the surgery in patient with severe comminution. But I would say if your patient choice is correct, if you are doing this surgery in which you feel that there is no anterior reconstruction required, then it can give you good results. Cost definitely is one concern, because these screws are much more costlier than the conventional pedicle screws. And one definite concern, which I think most of the orthopedic and spine surgeons we tend to ignore, is the radiation hazard. You probably can do an open pedicle screw fixation with 4 or 5 cm shots. However, you would need to take at least 30 to 40, I would say minimum, cm shots if you are doing even a short segment fixation with percutaneous technique. So this is one disadvantage of the percutaneous technique. So this was the last surgical concern, and I think I would like to summarize my talk here, that for thoracolumbar injuries management, a detailed clinical and radiological evaluation is absolute must. You need to study your CT scans, MRIs, X-rays very carefully to decide whether to operate, how long fixation must be there, whether to add fusion, whether you can use minimally invasive techniques. You have to start using appropriate classification techniques for understanding and better communication. The most common ones, the most popular ones, most useful ones are AO classification, Dennis, and the Telix classification. For every fracture, for every patient, you have to individualize treatment. There is no copybook guideline algorithm which can be given. You have to individualize the treatment to your fracture based on the principles that we have discussed. And it is very important to discuss the expected outcomes with the patient in the light of available evidence. It should not be that your patient with complete paraplegia wakes up after surgery next day and asks you, Doctor Saab, my feet are not moving after the surgery. What is the benefit of surgery? This message should be driven into his mind before the surgery, that why are we operating? Thank you so much.
Thank you very much, Dr. Tarun. That was an excellent talk. And it was like a 2020. You covered so much in that 47 minutes. So now I request other panelists to ask any question they have, because yes, so
burst fractures. I congratulate you for that. And secondly, this short segment fixation, I can quote a paper from JBGS April 14, Koz et al. They're from Turkey.
Yes, sir.
They had said for the burst fracture, whether stable or unstable, you can have a short segment fixation with index level screw and cantilevered hyperlordotic reduction with a slightly about 15 degrees lordotic bend given to the rod itself.
Yes,
And
sir.
I have tried it in some cases, and really it gives good opening up of the fractured vertebral body, and it stables the recollapse rates have reduced with that concept. So,
Yes, sir. Definitely, it's a very good technique.
yeah, yeah. Anything else?
Yes, Dr.
So,
Priyank.
yeah, so Dr. Tarun, I have certain practical questions which I want you to answer on for our delegates. One is, as far as a conservative treatment is concerned, could you elaborate a little bit more? Like, when would you ask the patient to start mobilizing? Would you use any special type of brace so that we know what to do?
So yeah, I think that was one aspect of the talk which I should have covered in it. So in the conservative management in the indicated patients, we if it's a stable fracture that we are managing conservatively, like an A0 type or A1 type or A2 type, we generally put the patient on bed rest and allow him to be out of the bed with brace. The brace which I give is a conventional TLSO or a Taylor's brace, and allow them to be out of the bed as soon as they are comfortable. So if it's a stable fracture, like an A0, A1 compression fracture type, where I'm sure that there are no features of instability, I mobilize them as soon as they are comfortable and pain-free, which typically occurs between, I would say, 7 to 10 days. Varies between patient to patient. And I follow up these patients and get a check X-ray done after 4 to 6 weeks of the trauma to see that there is no progressive increase in the deformity and everything is going quite expected. For the second category, which is the unstable fracture patterns, for example, some patients with burst fractures might not want to go in for a surgery and they would like to opt for conservative treatment. I generally delay the bed rest or mobilization for 3 weeks. So I let the fracture fragments consolidate a little bit and then start mobilizing the patient gradually with the brace, again as per patient's pain tolerance. So that is again get a check X-ray done after 6 to 8 weeks to see that the fracture has stabilized and there is no progressive kyphosis.
Perfect. As far as the radiological follow-up is concerned, do you do special type of X-rays like a sitting supine X-ray, or do you just watch for the progression on a basic standing X-ray?
No, that's thank you for pointing that out, Dr. Priyank. That 6 weeks or X-ray, the follow-up X-ray that we do is a loading X-ray or a standing or a sitting X-ray, whatever the patient is comfortable in the brace, to see that what is the amount of physiological load that the fracture is about to take. A supine X-ray generally does not give you the true picture because the patient has been mobilizing. Picture may be changing between a supine versus a standing film, and if you're so we take both the X-rays, supine and a standing film, and compare the kyphosis between the two. And if there is any degree of kyphosis, I generally stagger the delay the mobilization bit, or I go back to my scans to see if I have missed any kind of injury or probably made a wrong choice.
Correct. Super.
Can you hear me, sir?
Yes,
Can I ask
Praveen.
few questions, please?
Yes.
Can you hear me, sir?
Yes, sir.
Yes.
Yeah, sir. It's excellent talk, sir. Thank you very much. I have certain points which I have noted down regarding A3 and A4, which is the gray area where we are in dilemma whether to operate or not to operate. So few points are very important, sir. As far as conservative line of treatment in those fractures, one thing is how long we keep the patient bedridden. Second, in conservative management, when we start them mobilizing, what is the duration of the mobilization? Third, whether they have deficits, they have progressive deficits, or the deficit has regressed, and that is also a very important point. So I feel, in my opinion, in A3 and A4, where there is a total gray area, we should give a benefit of doubt to the surgeon and not to the injury. And I feel we should operate these cases because the amount of bed rest needed is huge. If the patient have even a mild deficits, they may be bedridden and they may develop other complications like lung infections, or they may develop bed sores. So these are the other complications. And earlier we mobilize, we'll get the better physical outcome of the patient. Hello?
Hello.
Yeah,
Yeah. So
yes.
your
Yeah.
concern,
So regarding A3 and A4, where we are in a dilemma or where there is a gray area where whether to operate or not to operate is a question. So in my opinion, we should give benefit of doubt to the surgeon and not to the injury itself, sir. In my opinion.
your concern is absolutely justified, Dr. Praveen. Being surgeons, we always feel that we will be able to give better outcomes, and I would definitely say, although my approach is also the same, it resonates with you. But I also feel that a practice of conservative treatment is a dying art, and the literature is not favoring the surgeons. Most of the literature, including the recent literature, is showing the same what it was showing 10 years back, that the results of the operative and non-operative, especially in the long-term results and systemic reviews and meta-analysis, are comparable. So, however, we feel that in our understanding we are justifying the surgery, but still the literature is not strongly giving us a back.
A few more points, sir. Can I? Can I?
Yes, Praveen.
So, sir, in patients with no deficit and patients lying in A3 and A4, do you wait for 72 hours, as you mentioned, for every patient for 72 hours, sir?
No, I operate them as early as possible. That
As
usually
early
is
as
what's
possible.
possible.
Exactly.
Earliest possible might be in a private setup in the next morning OT list if you decide
Right,
for
sir.
surgery. I work in a
Exactly.
government setup, so in any case, it takes 3 days or more than that. So, but that slide actually conveyed the message that if possible, it should be done within the 72-hour window or as
Sure.
early as possible.
Right, sir. Right, sir. And last question by my side, sir. Do you recommend CT in all thoracolumbar spine fractures, sir? Every.
I do not do it in an A0 or an suspected A0 or an A1 injury. But for anything beyond that, I generally get a CT done.
Thank you. Thank you very much, sir. Thank you very much.
Quite good results and quite a lot of information which you can get from CT, the coronal. Yes. So now really I am also feeling that for every case really we should go in, especially when we are thinking of treating surgically. Because you can get the idea about the pedicles, the posterior ligamentous complex, whether it is a bony injury of PLC or whether it is a ligamentous injury. All these things CT will tell us much better than MRI.
Absolutely.
Yeah, in fact, sometimes I've noticed it's easier to identify a A1 or a A0, let's say a transverse process fracture, more on a CT than actually studying on the X-ray.
Right.
So it helps us a lot. Dr. Tarun, I have certain questions on surgical tips and tricks, especially when we are talking in terms of decompression. You know, there's been a lot of discussion earlier as to what is the adequacy of decompression, and there are a lot of surgeons who wait or keep decompressing till they see any pulsations in the cord. So can you throw some light on that as to how much important on-table pulsations of cord is to judge the adequacy of decompression?
Dr. Priyank, that's a very tricky question.
Yeah.
I have not been able to get answer at my fellowship from any of the leading surgeons in any of the conferences. As a young surgeon, that was one question that I always had in my mind.
Correct.
But after being in the active surgical field for so long, myself as an operating surgeon for so long, I actually feel that there is no answer. It is, I mean, your experience only tells us that whether you have achieved adequate decompression or not. Cord pulsation definitely is not a reliable sign. It is not a reliable sign. We have seen so many patients in which we could not document cord pulsation, but they have recovered pretty well. And a presence and restoration of cord pulsation also does not mean that the patient will recover.
Correct.
So I mean, it's still an unanswered question. I mean,
yeah, and I also absolutely second that. But I've seen a lot of times, you know, we are waiting on the table for the pulsations to get up, which kind of I wanted as a take home that don't bother about the cord pulsations as long as your tips are correct and you know, you are able to adequately feel that the cord is free from undersurface. That's good enough, and you have done your job.
Yes.
It is just like saying how much disc you remove in a disc.
Correct. Absolutely. Absolutely.
Adequacy of disc, just like that.
One other topic I wanted to touch base upon is the use of crosslink. How many times do you really use crosslink, and do you feel that can we do with or without them?
Okay. So again, the literature shows there is no added benefit in till type B injuries. That is
Correct.
one, that is clear. For type C injuries, which is the fracture dislocations, I generally most of the times add a crosslink in the fracture dislocations because they are 3-column injuries with extensive ligamentous disruption. But for rest, all other injuries, I generally do not add a crosslink if I'm operating a young patient with a good bone stock. An osteoporotic patient, old patient, makes the totally changes the game. In that, I might want to add in a crosslink to add an, more instability to the construct and prevent what is called the parallelogram effect.
Correct.
But in a young patient with a acute trauma, not a fracture dislocation, I generally do not add a crosslink.
Okay,
Correct.
corollary to that, Tarun,
Yes, sir.
if you have a fracture where the pedicle is broken and you are unable to put the screws in that segment, but you are able to put above and below, in that case, do you add this crossbars, cross things?
Uh, I don't, sir. I don't. But many people say that many studies have. I'm not many, but few studies have come up which say that if you are able to put only one index screw, it is better to extend your level
Yes.
because and some people also say that if you are adding decompression for adding doing the decompression, you're removing one side pedicle. So you are removing the facet joint and the pedicle on one side. So that creates some sort of inherent stability, and you will not be able to use that side pedicle for index screw. You can only put one pedicle screw to the opposite side. So it is better to extend one level. The concern that you might be sacrificing motion segments, many studies, including one by Dr. Hitesh Modi, he has said that you can put one additional screw at the top where losing motion segment will not be a concern. You don't want to add a screw in the lumbar spine, it's understood. But then add a screw on the top in the thoracic region where the loss of motion segment will not be a concern and might add to the stability of your construct.
Okay.
Correct. In fact, I do the same thing. If suppose I know that I'm not able to pass two index screws, and I would just not bother with that. I'll just go two above, two below, and be more, sleep peacefully at night.
Yes, absolutely.
What Tarun said is two above and one below. What you
So
are telling is two above and two
yes.
below.
So
Because that's the, you will be fixing the lumbar segment, which is a
correct.
mobile one.
Correct. But extrapolating from the scoliosis studies that we have been doing, where they are trying to squeeze one level above the other level, there are studies which have shown that if you have got more than two lumbar disc, then saving one more disc is not going to make a big difference. So usually thoracolumbar, you are either ending at L1 and L2. So as far as sacrificing taking one more lumbar level while not having that much stability, I would push for one more level and sleep peacefully. That's what the concept what I had.
And I would like to ask, I usually have found that really you get good support or good purchase in the index vertebra. What's your experience? Most of the times you can get that. Of course, it
Yes.
will all depend upon how much combination, but most of the times you can, especially in burst fractures, you can get really good purchase in the index, and so you can go in for a.
I think the key is that you have to plan your index screw. I mean, you
Yeah.
have to study your CT scans very carefully, look at the pedicle cuts on both sides and see where the adequate bone stock is there. So it
Yeah.
always is the oblique screw, which is the most common combination in the burst fracture is in the posterior superior part. So you have to put the screw in such a way, take a superior entry point and direct it inferiorly so that it goes into the, so that is the key.
Yeah.
And finally, how often do you actually do a resurgery to remove the implants? In
Never,
never.
never.
Yeah.
I have discussed it a lot in many. I mean, I have not been able to get hold on any study, but I have been told that there are studies which show in the patients in which the implants have been removed after 1 year. They say that the motion segment at that level has already become so much stiff because of mobilization that you do not get any benefit of regaining the motion. So I have never removed. I have 5 or 6 year follow-ups also of percutaneous screws without fusion, and thank God nobody of them has shown any failure. So I think that might be an overkill.
What is the rate of screw breakage gradually in due course of time? Because the patient do come with screw broken and after 10 years, 15 years like that.
So generally, if the screw has to break, it will break within the first 2 years. If the fusion has taken place, the fracture has healed. Generally, then it becomes a load sharing implant. Most of the loads get transmitted through the spine, and generally the implant failure does not occur after that. So unless there is a failure of fusion, unless your planning is not being correct, that your kyphosis was too much, there was extensive ligamentous injuries, and you fail to address to that, you fail to add the fusion, more stress is occurring in the implants. So the most of the screw failures will occur within the first 18 to 24 months if they have to occur.
So
Yeah,
can I add a little bit to it, sir?
Yeah. Yes. Priyank.
So what I've also noticed is patients with a total para with a fracture dislocation, type C injuries, where they have even lost their truncal balance. And those patients where we are, in those patients, I have seen screw breakage is very common because they really, since the truncal balance is lost, even when they sit, the stresses on the implants are very high. So such patients where I'm doing surgery only for rehabilitation and realignment, I tend to go more than less. So I use osteoporotic principles like 3 above, 3 below, or even sometimes 4 above, 4 below, so that because at the end of the day, I know I'm not going to get any neurological recovery. I might as well use more screws, cobalt chrome rods to give them that thing for life rather than worrying about implant failure. Because in these patients, anyways, it's not going to benefit, by saving levels and all.
Okay.
Yeah, and what I feel is that basically screw breakage, if it occurs after 1.5 years, the pulling out of the proximal or the upper screws, which occurs in some osteoporotic patients, and they are coming percutaneously giving trouble, there you can think of really removing the, if it is really giving trouble, or even I have seen them causing some sores on the back. Then there you have to remove, but breakage of screw is okay.
Many a time we see that once we are operated, but whatever the reason we are removing the implant, though we have not done bone grafting, many a time it will be fused.
Yeah,
Just
yeah.
because of the periosteal elevation and other thing. So my question is whether the bone grafting is really necessary when you are just elevating the periosteum. Many of the time, all this bone. Yeah.
Sir, if it is indicated, if you feel it is required, then you cannot rely on the principle in an adult or an old patient. I mean, in a child, you probably can require autofusion will occur because of periosteal chipping. But if you feel that you need to add fusion because the injury demands it, I think it would be safer to add it rather than relying on that it will be autofused.
Okay.
Yeah, what I have seen is the shingling and adding posterolateral grafts. One sort of, it was such a difficult thing to remove the implant because so much of bone had formed that really you had to, we had to osteotomize that much of bone to remove the screws and everything. And the rods were totally covered by the bone.
Correct. Yeah. Even I
Can
have
I put a
experienced
point,
the same.
please?
Yes.
Can I put a point in this matter?
Yes, Praveen.
In my opinion, sir, what I have learned from my bosses in fellowships, so what they used to do is they always used to make the undersurface raw, and then only they used to do the bone grafting.
So shingling,
just
shingling.
Yeah.
They used to make the surfaces raw with the bone burr.
Yeah.
And then only they used to do the bone graft because they found it's always better union when you do the surfacing, raw surfacing. Rather than putting just bone pieces over the lateral pedicle, it will not help to that extent, and union will never occur because of that bone graft until unless the undersurface is made raw.
When we are putting bone up, definitely we are doing either with an osteotome or something. We'll be doing shingling, doing the posterior cortex. We don't keep the bone up without doing that.
We're always preparing the bed.
Bed, right, sir.
Otherwise, even the transverse process will try to nibble it out and put them. Yeah.
Transverse fusion.
Yes.
And now we are seeing more and more gray zone cases. Thoracolumbar trauma, with trauma principles we are operating, but turns out that the patient is osteoporotic even at 50. We are seeing that in our Indian population as compared to the Western population, the osteoporosis is much sooner. So anything different you do in these patients at the time of surgery or after surgery?
No, you are saying that osteoporosis you just found out during the surgery, or you were able to document?
Yeah, so basically it has had a significant trauma after which the patient has had a fracture, but intra-op you find that they are not like those normal patients. They are osteoporotic. You're not getting any good holds.
Yeah, because a patient with 50, I would not probably get a preoperative T-score.
Correct. Yes.
So I will be caught during the surgery.
Correct.
So if definitely if I feel during the probing and during putting screws that my purchase is not good. I mean, the only thing at that point of time where I haven't gone in unplanned is I can increase the number of levels of fixation.
Absolutely.
I can put in a cross connector. So I think that is the only salvage option that we have, and I'll obviously be guarded on the mobilization of that patient, give a post-operative brace.
Correct.
So that kind of changes you might have to do.
And maybe post surgery in such patients where I feel I'm not very good with the bone hold, I get a wrist DEXA scan done. And if that also proves osteoporosis, then I would aggressively treat osteoporosis with either denosumab or teriparatide or something.
Yes, absolutely.
And lastly, in all patients post-operatively, what is the panel's opinion? Do you use braces for a regular fixed patient post-operatively?
No.
I don't use it.
Not for a fixed patient, operated patient. Yeah, definitely for a conserved patient.
Correct. And just like Dr. Tarun said, if suppose we find that the bone quality is not good or our holds are not good, then maybe a brace is okay. Otherwise, in general, braces are not needed.
And
Brace is okay only that's for our mental satisfaction. It doesn't work.
Well said.
I would like to add in that osteoporotic fracture thing, sir. Recently, we are getting the screws with the differential threads in the spine also, where the pedicle has a very small thread, and the distal part of the screw, which will go into the body, we have a larger threads. So we can think of using them, but they're very expensive.
Thread means the diameter is more or the pitch is more?
No. The pitch is less in the pedicle area.
Okay.
So there is a differential thread in the pedicle screw. The pitch thread is less in the pedicle area, so they will have better purchase and better hold in the pedicle area.
The pedicle pitch is like a cortical screw, and the body pitch.
Right, sir. Yeah, exactly. Right, sir. So in osteoporotic patients, we might think of it, but they are expensive, and I have barely seen 2 or 3 companies making it. Not used. Even
it cannot be differential pitches there, because when you are putting the screw, one rotation in the body has to be one rotation in the pedicle also. Probably there are double threads there, one within the other. So if there is a thread at 1 millimeter at the body level, it's a 0.5 millimeter. There is 2 threads which are going parallelly, so that your rotation has to be same. It is not like a differential pitch Herbert screw.
Right.
What I want to say is that the cancellous type of threads in the front
body
portion
and the cortical type in the
threads in the pedicle.
Right, right.
Can I ask one question to the panel? How many of you use steroids for a patient coming within say 8 hours of injury?
We have used before the article came. No, we have used enough number of cases. At least myself and Bandari, we are in the practice for 30 years. We have more than 30. Dr. Bandari is 35 years. So we have used earlier. For the last 10 years, we have not stopped using it. Probably.
Yeah.
Yes.
I use steroids. Of course, I don't follow the NACES criteria with such high dose steroid, but 1 gram methylprednisolone every day I start as soon as the patient is getting admitted, just with the thought that it's not going to do a lot of harm unless there is some gross problem like the patients have sugars more than 300 and all those. I would not shy away from using steroids, and if needed, start insulin along with that, talking to the physician.
I have seen many neurosurgeons using just a single dose of methylprednisolone post-operatively immediately, and that's all.
Correct.
Even any spine surgery, not necessarily the trauma surgery.
Correct. And it's still a controversial topic. Like, still we don't have that absolute evidence saying that you should use or you shouldn't use. So I think it's at the discretion of the doctor. Some people use and some don't.
No, that was actually, it was a misquoted one.
Correct.
At 6 weeks time, there was a significant, probably some change in the recovery rate, but at 3 months and 6 months, there was nothing. That's what the paper really quoted. Yeah.
Shiva, actually what I want to say is that high dose, I have never used really. That high dose, which they said every hour, every 2 hours, and all those things. That NACES studies told such a high dose.
Yes, cost is a constraint, but definitely we have used 6 hourly or 8 hourly doses in those cases.
Yeah, ulcers and people have developed with that high dose.
Yes, Praveen.
Sir, apart from neurological recovery, steroid has a lot of benefits also, sir. Like it reduces inflammation really fast. So it's, in my opinion, it reduces inflammation really fast. Apart from, there are 2-3 benefits which I don't remember exactly word to word. but inflammation reduction is really good with steroids. So there is no harm in giving.
Now you can say it prevents leukotriene storm.
Yeah, right, sir.
Like that.
Exactly, something like that.
Giving Decadron 4 milligram video is something, but what Nassis had said is about methylprednisolone very high dose. That we don't follow.
That
Definitely. Post-operatively dexamethasone 4 milligram BD or then OD and something like that. That we may use, but not that high dose methylprednisolone. Definitely.
Right, sir.
Yes. Okay. I think we are deviating too much from the main talk. Anything else?
No.
Suri, to
Sir,
add
can
up? Yeah, Praveen.
Can I say I need some guidance regarding one point. I'm deviating a little bit from a main thoracolumbar topic, but I have felt it little difficult when operating proximal thoracic fracture, sir. Somewhere between T3, T4, and T5. Uh, uh, are you able to hear, sir?
Yeah. What
Yes.
kind of difficulty apart from the imaging? The intraoperative imaging,
and
that is
while
one.
intraoperative, while marking the levels, because shoulders do come in between.
That is,
And
I think we rely more on the AP view for proximal
Okay,
thoracic fractures. We start from the last rib and C71, and that's how we take it down. Till D4, D5, the lateral view CM is very unreliable.
Right. Fine. Thank you.
Okay. I think there are no more questions. Thank you, Dr. Tarun Suri, for that wonderful exposure to the thoracolumbar injuries. And really, you have covered so much in such a short time. Those who will see afterward this talk, which will be definitely there in the archives of OrthoTV, people will realize that the usefulness of this talk whenever we are going to operate the next case. Definitely, I am at least going to look at this talk first, then order the investigations and get the things properly done. Thank you very much. I would like to thank Dr. Priyank Patel and Dr. Praveen Sarda and Dr. Sang Gururaj for joining and taking the discussion in the right direction. I would also like to thank Dr. Sanjeev Bhandari, who accepted my invitation in the last moment because Dr. Sudhanshu Kotadia was unable to join today. So Dr. Sanjeev Bhandari readily accepted, and he has done a great job for being on the panel today. Thank you very much, Dr. Bhandari, for sharing your experience. Thank you all. Before I close this meeting, I would like to remind you that the day after tomorrow,